about myofunctional therapy from a dentist. That I was a dental hygienist, and we moved to California from Chicago. This is my hometown. And my son, my other son, Brian, his little brother had a lot of problems. So ADHD, colic, headaches, jaw pain, took his tonsils and adenoids at 3, and they didn't do it. He couldn't breathe. He had failure to thrive. And he couldn't go to school. He couldn't focus. And I took him everywhere to try to find an answer. They put him on medication. They did all kind of therapies, speech therapy, vision therapy, the psychologist, everything. And finally, they sent me to neurology, and they wanted to do brain surgery on him. And at the time, I was working for a dentist who was very forward-thinking. His name was Wes Leffingwell, and he was down in Cardiff, California, by San Diego. And he said, before you do surgery, let me take a look at him. And I said, sure. He said, you know, I just took a course on myofunctional therapy, and I think his tongue is in the wrong place. I said, what? And I had been teaching at Indiana University, and I was like, I never heard of such a thing. The tongue is in the wrong place. She said, yeah, look at his palate. It's very high and narrow. And watch his breathing, his mouth breathing. He said, you need to do these exercises. I'm going to make a little appliance to help facilitate forward growth and wider. And I want you to see an osteopath. And this was a long time ago. This was like 43 years ago. And I said, what's an osteopath? I never heard of an osteopath. And he said, well, there's only 2 in the country, but there is one in San Diego. So anyway, he knew her, Viola Fryman, and got me an appointment. I did everything he said. Within 3 weeks, his headaches stopped. 3 months later, I noticed his teeth started straightening out. He was sleeping. He started eating. He didn't like to eat. He couldn't smell, because when you mouth breathe, you don't smell. So I figured I need to learn this. So the only place teaching at the time was in Coral Gables, Florida, with Dan Garliner. I took his class, came back, and then I found out there was an association called the AAO, and I joined that. And here I am, and started teaching courses with the AOMT, which we started. And here I am. So without further ado, you're going to see some things today. And through the years, I met our froggy mouth guy, Dr. Fellers. And I met him in Bordeaux at a meeting with Christian Guilleminault, and Mark was there. He was an exhibitor, but Mark said, Mom, he's an orthodontist. You need to listen to him. But he spoke French. He did not speak English. And I did not speak French. And he saw my name tag, myofunctional. Ah, he said, you must use these froggy mouths. And I thought, well, what would I use this for? I'd never seen anything. It was a thing that covered your lips. And I thought, maybe it will help lip seal. So it'll help the muscles of the lips to close. So I bought a bunch, and I was using them with patients, telling them you got to push down to strengthen your lips. But I don't know, the patients liked them. It was kind of hard to close your mouth. But I thought, okay, they're interesting. We're talking about the froggy mouth. And I was wrong, because when I learned how to use it, I was using it all wrong. And since finding out how to use it right, I love it. Every patient in my practice gets one. And I've noticed a big change. You're going to see a change recently that I worked on with a patient. So I've written some things too. I've written 11 chapters in textbooks, and I wrote a children's book. So some objectives here, we're going to define what it is, myofunctional therapy, how we can help the orthodontist be more successful, and how habits may affect the orthodontic result, and the big picture, obstructive sleep apnea, orthodontic relapse, and orofacial pain. So what is myofunctional therapy? It's actually neuromuscular re-education. And we work with habits. We work on breathing re-education. We really push that hard. All of our students have to learn about breathing re-education. We develop a lip seal and toned lips, attain a palatal tongue rest position, both anterior and posterior. We work to isolate, activate, and elevate the back of the tongue. Primary focus, back of the tongue. We tone the pharyngeal muscles, and we work on functional posture training. I'm not a physical therapist. If getting the tongue to work helps the posture, so be it. But I do work collaboratively in my practice with physical therapists and osteopaths. And we tone the pharyngeal muscles. We work on correct swallowing and chewing in stage 1 swallow. Make that clear, because I don't do dysphagia, although it inadvertently happens. And I don't work with little babies other than to record that I did refer, and I get good results that way, and create a correct swallowing pattern. So you've seen this diagram. I put this together a long time ago. These disorders are not just related to teeth. It has to do with obstructive sleep apnea, orofacial pain, learning and behavioral problems, nutritional and digestive problems. This is really critical. I studied nutrition a long time ago to help my son, Brian. And there was no sugar, we did the Feingold diet, but I studied more than that, how to eat the correct fats and low sugar and fruits and vegetables and protein. It's mainly, and good water. Speech and language problems, I don't do that, but they do self-correct sometimes. If they don't, I'm sending them to the speech pathologist. Posture problems, the same thing. Getting the tongue up sometimes can help the posture. If it doesn't, I'm referring. And orthodontic relapse. So why, how, and when? Why orthodontists need to know about this is to avoid sleep issues, orofacial pain, orthodontic relapse, behavior and learning disabilities. If the child is not corrected by the age of 5, by the time they're 7, they can have a lot more, at least 50% more learning and behavior problems. Parents don't want that for their children. And how? Well, we recommend breastfeeding, of course, habit elimination, chewing and proper breathing, complete myofunctional therapy. I see so many people that come in to see me and they said, well, we watched those YouTube videos or we went to a dentist who did myofunctional therapy and used these appliances. And I worked with the therapist before, but she said I was pretty much done after 3 or 4 weeks, and it comes back. If you don't do complete treatment in my book is following your patient for a minimum of a year and then do a 3-month follow-up. When prenatal education, you just heard Dr. Ono talk about that. Infancy, before age 7, is ideal just to do myofunctional therapy, but throughout the patient's life. So the tongue actually connects all the way to the feet with fascial tissue. So it's really the start of your spine. It's very important that you understand that. There's a new article, I think Mark talked about it, the Roadmap for Craniofacial Growth and Modification. Audrey Yoon, David Gazelle, and Kashida. These are people, big people. We call them big because they're people that work with universities and are very highly respected in the medical and dental field. And I love how the bottom line, the red line there, talks about myofunctional therapy throughout the whole age of that child developing, from age 0 all the way to 18. And they mention different things that they do with expansion and different things for tonsillectomy, adenoidectomy, but myofunctional is throughout the whole thing. And there's research showing that taking the tonsils out and adenoids by itself isn't the total answer because you haven't changed the behavior and the function. And Danny Eckert was on this study we trained his whole staff in Australia. He's a researcher from Harvard originally. And we saw finally, he mentioned 36% of patients with obstructive sleep apnea had minimal genioglossus muscle responsiveness during sleep. And I thought that was exciting, but listening this morning to Darius's talk is unbelievable. They know it's the function of the tongue, the back of the tongue, that's involved in sleep problems. And this study's been out there. We have, I think, 4 or 5 meta-analyses now. So it's exciting. And so how this may assist the orthodontist, and this is very important because we've all worked in our little silos for years, but it's urgent now that we all come and work together because society in general is, first of all, recognizing that they can't sleep. You just turn on any television, you'll hear about all the sleep aids that are out there. But they want more referrals. The very top doctors in this country are embracing myofunctional therapy, and they're finding that they get so many more referrals. People look at their website. If it says myofunctional therapy, they're going to call that one. The family's tired of sleepless nights. The kids are causing the parents to lose sleep. They can't work, they can't function. The ADHD problems, behavior, learning problems. And my son Brian, they would call me 3 times a week, come and get your son. He's got another skull crusher. It was horrible. And the patients are more compliant with wearing appliances. The myofunctional therapy may be an extended team member. After I learned about myofunctional therapy, I worked in 3 different orthodontic offices. And they loved me. They just loved me because I made sure that they wore their rubber bands at the right time. I made sure they kept their retainers in. I made sure they cleaned under the wires, because my background of hygiene, I'm a fanatic. So it was They loved having me in their practice. And then I moved to Los Angeles, where there was 10 million people and not one myofunctional therapist. So I got real busy real fast. So I started teaching more. Habit elimination, just working on habits, the awareness of habits. Most orthodontists do not understand tongue sucking or nail biting and what it can do to destroy the results they get. The patient's family appreciates your work on a different level. You saved our family. You saved our family, not just Johnny, but our whole family. We were arguing and fighting all the time because Johnny was so bad at the problems. More long-term stability without years of retention. The mothers that come back to the practice, look at Johnny's teeth, they moved. Costs a lot of money. And less missed appointments due to illness, because these children are sick all the time. And the function, influence on form, this child is not pulling the maxilla forward. This child is pushing the mandible back, which is blocking the airway. And they may interfere with orthodontic treatment. The patient isn't aware. And what about the bacterial challenges with COVID, putting everything in their mouth, constantly touching their face and rubbing their eyes? Emotional benefit of choice to quit the habit. This is huge. You're going to see this. This is huge because the child who cannot quit sucking their thumb, and you're putting an appliance in to stop the thumb sucking without engaging the child, they learned that they're powerless over their addiction, something that feels good. But what we do is give them the power to decide to quit, and then we assist them. It's critical. The orthodontist treatment plan will be enhanced without that habit constantly being in the way. And we are trained in all these habits and more. More. Just touching your face. The last one on this, the sleep position, I think is huge, and we don't understand it or recognize it enough. Sleeping on your side can create a long face syndrome. This girl only slept on her right side. She was in those braces for 8 years. And he couldn't get the bite to close. He put the rubber bands on and it would pop open. And so it went off of that slide. So these are some oral habits, and there's some studies on it. Okay, so with the tongue tie, patients may choke on their tongue if they're on their back. So that's why the medical doctors say, oh, put a tennis ball in the middle of their back so they don't sleep on their back. But their tongue is choking them when they're on their back if they're tongue-tied. With jaw pain, if you're sleeping on your side, it's going to move the mandible and the disc is going to slip and it's going to pinch the nerve after a while. Not on everyone, on some people, especially if they sleep on the same side. But even on both sides, it's going to cause a long face syndrome. With back pain, they may have to put a pillow under their knees to take the pressure off their back. But if you elevate the bed the size of a brick, then the tongue, even if it's tied, will drop forward and get out of the airway. Well, that's not the solution, because I think it's better to sleep in a flat bed, but it's something for a while that will help. But taping your lips may help if the nasal airway is open. And there's a whole process of lip taping. But I received this from a dentist who drew a picture of how the face is tilted like that when you're sleeping on your side. So he recommended this elevation of the head of the bed. And there is a study on that proved that mild head of bed significantly improves obstructive sleep apnea severity without interfering with sleep architecture. It's a simple alternative to treatment. It helps. It's just another help. And those of you, we went to the Northwestern Sleep Lab, you heard my patients say, you know, I elevated the bed and it did help me sleep, right? Yeah. So there are a lot of standardized frameworks on sleep position. But I tell my patients, you're sleeping on your side now, I can tell. However, our goal is to get you on your back after you've had any restriction and your tongue taken off, if we can. If not, we'll get you a special kind of pillow. They have a lot of sleep pillows that are like a big S that you can sleep on, so there's no pressure on your face. So these are some habits we talked about. So these are the things that people don't realize they're deforming their children. It's the pacifiers and baby bottles and even baby food, the baby-led weaning we talked about earlier. So we have to kind of be aware of that. These, I think, are dangerous. Seriously. The kids love them. They're fun. They put sugar in a lot of them, but even the organic ones. What this is doing, it's a whole new generation. I had a 4.5-year-old in my practice 2 weeks ago. The mother is my patient. She brought her 4.5-year-old, and I looked at her bite, cute little girl, but she had a bilateral major open bite. Major open bite. So I said, what are you eating? I said, what do you usually eat for breakfast? She said, pouches. I said, what do you eat for lunch? Pouches. What do you eat for dinner? Pouches. And I'm like, Mom, they need to chew. And she said, well, this is LA schools. And she said, what do you think about eating something else and chewing to a little girl? And she puts her hand on her waist and she says, it's my body and I'll do what I want with it. So I was like, okay. But I gave her some chewing tools and she loved them. So I talked to Mom later and she said she's starting to chew. She likes to chew. It feels good to chew. But I think they're going to cause more problems, keep the orthodontist busy for a long time. But weaning baby food may actually, by baby food, may slow down the establishment of chewing patterns. Kids don't know it feels good to chew. Chewing is very important. And this, I think, is not looked at enough, this facial grimace and how it can affect the temporomandibular joint, because it's using all these muscles, because they're tongue thrusting, right? Their tongue is coming forward. To stop the food from coming out of their mouth, they have to use the wrong muscles by grimacing, overdeveloping the mentalis muscle, but also critically affecting muscles that support the jaw. So that's one of our goals, is to stop the facial grimace. This little girl had headaches, major headaches, and they went away. And this little girl had serious sinus infections constantly. And you could see how her mandible came forward. And her long face got shorter. Can you see that? So the atypical swallowing, most orthodontists are used to dealing with this. It's frustrating for them. We can help them. We can become an extended team member and help them get a faster, better, more stable result. So it's very important that orthodontists team up with myofunctional therapists and work together, collaborate. This is a little girl who sucked her thumb, and she was referred to me by a young orthodontist, and she also had tongue thrust. She was sucking her thumb, thrusting. She was very compliant, and at the end of therapy, a year later, I sent her back to the orthodontist, and he had taken original photographs when she was 5 and said, she's too young for orthodontics, so come back when you're done with Joy. And he couldn't believe it. He called me up and he said, what did you do? It's a different mouth. And I said, well, I referred her back to you because she still has a little crossbite. And he took some x-rays and found out she was congenitally missing an anterior, but she did finish. And he was happy, she was happy, Mom was happy. I think they're gonna put an implant in when she's older. So breathing re-education is critical. Patrick McEwen, he works with the AOMT, does all our breathing education. He's very famous. He had asthma, and he studied with Dr. Buteyko in Russia over the turn of the century. And he does a lot of wonderful things, but he teaches with us. And Carlos was an ENT from, I think he was from Spain, yeah. And so they found that this works. This whole functional idea of breathing light, slow, and low is critical. So let's all do an exercise. I can show you how relaxed you'll get. You're going to breathe just through your nose. Your whole tongue is going to be suctioned up to the palate. Your lips are closed. I want everybody to close their eyes. Take a small breath in through your nose. And when you breathe in, I want you to feel your diaphragm move out. And mainly the middle of your low back come out, like a belly breathing. Think of it like the inner tube that goes around the middle. Close your eyes, let's try it. And when you breathe in, it's 3, out is 5. Okay, let's try it. Small breath in, 1, 2, 3, exhale. 1, 2, 3, 4, 5. Breathe in, 1, 2, 3, exhale. 1, 2, 3, 4, 5. Small breath in, 1, 2, 3, and relax. 1, 2, 3, 4, 5. Breathe in, 1, 2, 3, and let go. 1, 2, 3, 4, 5. Okay, how many of you felt relaxed when you did you feel that sense? That's what we call moving your patient from sympathetic nervous system to parasympathetic. You're getting more oxygen in your body. We train patients to do that with many different exercises to get to that point, but it helps with your ability to fall asleep easy. I have them do it for 5 minutes before bed in the middle of the day. It releases a lot of stress, and it's really helped, you know, and they have to breathe through their nose. So you've got to make sure that nasal airway is open. So if they do mouth breathe, this is what's going to happen. The palate is going to collapse. And when the palate collapses, then the roof of your mouth is the floor of your nose. So as that collapses, people can't breathe and can't sleep. So the high narrow palate has been proven to be one clinical sign of obstructive sleep apnea. And myofunctional therapy is coming into vogue. This was another meta-analysis from the Brazilians. The Brazilians have been way ahead of us in a lot of ways because their speech team is all trained in myofunctional therapy. And they check the tongues when the baby's born to make sure that they're released. And palate expansion. Most orthodontists know that palate expansion will help the nasal airway. And what it does when you breathe through your mouth, the airway, actually the volume gets smaller in this study. So if they're nasal breathing, airway gets bigger. I like to show these pictures to patients. And this was one study I was on with Dr. Zaghi, who was a resident at Stanford. He's now an ear, nose, and throat specialist and a sleep specialist. And he teaches, he's devoted his whole practice to looking at tongue ties and how it affects sleep. So this was 348 cases, and they were mostly people that had tongue tie and sleep problems or jaw problems. And you could look at the percentage of improvement. It's huge. It's hard to deny the research. Is that Cerritos Zaghi? And Audrey Yoon and Dr. Zaghi did this study and found that restricted tongue mobility was associated with narrowing of the maxillary arch. So not only will the tongue cause sleep apnea, like what Darius said this morning, but it'll also cause a high narrow palate and crowded teeth, right? We talked about that. So how do you detect a tongue tie? Well, there's basically two different, the anterior tongue and the posterior tongue tie. In my practice, I see a lot more posterior tongue tie lately. At first it was only anterior, but now it's posterior. Why we're having more posterior ties? There's a lot of research that needs to be done to find out why that fascial tissue is not growing right. And for a posterior tongue tie, you want to look for the dip in the tongue. The dip in the tongue is a pull down. It's very slight in some patients. Also, if they try to put their tongue on the corners of their mouth, does the whole mandible shift with the tongue? I look at that. That dip or that restriction in the middle of the tongue is an indication that there may be a posterior tongue tie, especially you have to look at the symptoms that patient is having. And you could also measure how far the patient can open and then have them put the tip of their tongue up and see how far they can open. And that'll tell you if it's more than 70%, you're kind of in the normal range, but anything below that is restriction. And let's talk about relapse, because I see this in my practice a lot. The patients have worn braces and then the bite open. And they have to be retreated. I've had patients that have had 4 or 5 orthodontic treatments, and that's what they do. They've worn braces most of their life, you know. And they have permanent retainers put in, and even with the permanent retainers, they're still pushing out. And I see these open bites all the time in my practice. And sometimes it's unilateral or bilateral, depending where those muscles. One thing I don't think people realize, there's 16 muscles inside the tongue, and they all have different functions. So we need to work on all of those muscles to get those muscles working right. And I see this a lot in my practice. This boy had an orthodontic relapse, came to me, and he's doing pretty well. And I sent him back for, make sure he's wearing the right retainer or Invisalign or whatever. But you can see how his face came forward. And this was just with a year of myofunctional therapy. I did the breathing re-education, and also he had his tongue released. And the relapse is not just with orthodontics. Sometimes it's relapse of, keep going the wrong way. It's relapse of nasal surgery. And I've seen these empty nose syndromes with people. So if you don't change the function, you'll have problems. I guarantee. Sometime in your life. Because muscles trump bone, muscles trump teeth. The only thing muscles do not trump is airway. If you can't breathe, you're going to do whatever you can to breathe. And what we try to do is develop the face forward, develop the maxilla forward sometimes, and work on the Mallampati score. And we see the scallops on the sides of the tongue. We work on that. And this study was done by two doctors from Rome, Italy, the Olivis, and they actually came to our first AAMS meeting. And he proved that having your tongue released can change posture. And they did myofunctional therapy along with it. So it was really interesting. And what's going on in today's world, we have texting. I look around the room here and I see 1, 2, 3, 4 people sitting like this, right here. And this health, 5 back there, 6. I see people bending their head, but you ever drive down the street and you see all these kids walking with the text, It's dangerous. But it isn't just texting, it's computers. Computer posture, ergonomics is not taught enough. And they start with babies. They give them a phone to play with while they're waiting for dinner to be served. And the babies are into it. So what treatment looks like is we have 4 phases. We do pre-treatment, which is habit elimination, an intensive phase, which is 8 to 10 or 11 weeks if they need frenectomy. The maintenance and generalization, it's the next 4 months, and then habituation until the year is complete. And this patient was referred to me, some of you have probably seen this patient before. He was referred to me by his dad, who's a pediatrician, and he had all these problems, Tourette's and posture issues, snoring. He had failure to thrive. He had expansion and braces before he came in. He had headaches, stomach aches, and he had a posterior tie. And you can't just cut the tie.
This is Thomas, and Thomas is just starting myofunctional therapy today, which is November 18, 2016. And can you tell me, Thomas, why you're doing this and what you hope to accomplish?
I'm doing this to stop my tics and improve and breathe through my nose all the time. And I hope to accomplish everything that Joy gives me.
Good.
And
help your posture
yeah,
too?
help my posture.
You swivel your chair and look that way once. Yeah, so we have a little forward head posture and then the other way. Yeah, good. And anything else that you want to accomplish or tips?
I want to accomplish putting my shoulders back more.
Having your tongue go
Yeah.
up. Okay. feel in the right place all the time and swallow.
Yeah.
Help your airway.
I think that's it.
I think that's it too. Very good.
So this was him at 7 months, and he was doing better, but when I finished him, can you hit it? No.
So this is Thomas, and Thomas is now completely done with myofunctional therapy. And can you tell everybody in the audience what your thoughts are about it, how it's helped you?
When I first started, my head was really forward, and my eyes were ticking almost every 3 seconds. And over this time that I've been with Joy, I've really improved. As you can see right now, I'm blinking with both my eyes, not winking anymore.
How's your sleep and all this?
So I used to snore and sleep on my side, and that affected my sleeping and breathing.
Now you're sleeping pretty well.
Yeah.
You're sleeping on your back and breathing through your nose all the time too, right?
Yeah.
Can you swivel your chair so we can just take a look at your posture? Wow, look at that. And then the other side too. Yes. Wow, look at that. Really good, Thomas. Well, it's been a real pleasure to treat you, and I'm hoping.
So this next patient is, she was set up to have MMA surgery in a month, and she's a physical therapist. And I treated her for like 6 weeks, I think, before she went in for surgery. But she was angry because in doing these exercises, she realized that she could have fixed it when she was 13 and not have to wait. And this is her talking about it.
Okay, so this is AJ, and AJ is set up to have jaw surgery 1 month from now, right? November, what is your date?
November 16th.
And she is having MMA surgery, maxillary mandibular advancement. And you look really good, but I know your airway is really, really small, and you have sleep apnea, been diagnosed, and you are currently wearing a CPAP, correct?
Yeah, I am. And the front looks good, but from the side you can see how retracted I am.
Yeah, and you can't sleep or breathe. And AJ, you are a physical therapist too, and you were referred to me by Stanford University, and they're going to do the surgery in a month. And can you tell me what happened when you were younger with orthodontics?
Yeah, it was actually pretty frustrating because I had, your typical 2 rounds of braces. So my second round, I was finishing up when I was in 8th grade. And as they were taking my braces off, so I'd had them on for a year and a half, 2 years at that point. As they were taking them off, I was doing what I always did, which was, kind of swallowing and dealing with them in my mouth. And they're like, "Oh, you're a tongue thruster. That's going to be a problem." And they talked to my mom, and she asked what they could do about it. And they said, well, she'll probably end up needing surgery at some point. And they never mentioned myofunctional therapy or anything we could do to correct the tongue thrust. It just was kind of a foregone conclusion. So later when I became a PT, it was very frustrating looking back and realizing those were motor patterns I probably could have addressed at a young age.
Mm-hmm. Yeah, I'm really proud of you, and you've had a tongue release, and you've done all your exercises for the last 8-9 weeks, and you're going to see me 2 months after your orthodontic surgery. So I'm very excited. I'm sure you'll get a great result. The Stanford team is amazing. Thank you.
Thank you.
Well, if you looked at her profile, it didn't look that bad. She had a chin implant put in, and then they took it out, after the surgery. And then she had to have all kind of other things done. And she was getting married like 6 months later, so it was hard. This is another patient, and Dr. Fellis, I really want you to pay attention to this one, because this is when I really started getting into the froggy mouth. You know, about 2 years ago, I started making every single patient use of froggy mouth. But I hadn't used it on adults too much because you were always pediatric. But this lady, I was going to give everything to her. She was referred for surgery and to see me. She did not want to do the MMA surgery or the braces again. She had had a couple relapses. But she had migraines, TMJ, stomach aches, grinding. She had an anterior tongue tie. She also had lip ties. She had sleep disorders, drooling, speech problems. Her boyfriend actually made her come to see me. And this was her before myofunctional therapy. You can see how her teeth are splayed and her lower jaw's forward. Here she is a video.
Okay, so this is Sabrina, and we're just starting myofunctional therapy today, which is Tuesday, September 27th, 2022. And can you tell me, Sabrina, why you're doing this and what you hope to accomplish?
Well, to begin, I've always had an issue with just my facial appearance, first off, but I've had issues with being able to enunciate words, breathing properly. I've always been very out of breath from as far back as I can remember. And through the years, at least the past 10 years, I've noticed an increase in these issues, and it's become a very subconscious, very insecure thing. And I've been told surgery is the answer, and that's very terrifying being so young. And through many hours digging through the web and recommendations, I've found joy, and it seems as though I've gotten to the root source of the problem. So I'm hoping to relieve and actually find a solution that isn't barbaric and butchering of the body.
Good. And I think this will help your sleep, I'm hopeful.
Yeah, my sleep as well.
Which, once you're getting restorative sleep, then your body can fix itself on a lot of issues. And the bloating in your stomach and your grinding.
The fatigue, the grinding, the headaches and migraines.
Yeah, the headaches for sure. And your sore jaw.
Yeah, the tension in my jaw, the swelling, the asymmetries.
Yeah, and your posture. I mean, there's a lot of issues here that
there's a lot of things, and as I learn more and more about myofunctional therapy, it all correlates back.
Mm-hmm. Okay, well, let's get started.
Yes.
She was a very compliant patient. She did everything 3 times a day to the letter, including the froggy mouth and including everything I suggested, from osteopathy to habit elimination and sleep position and everything. And this is in 7 months. This was last week I took these pictures. And that's truth. I didn't do anything else. I sent this to the orthodontist, and he said, oh my God. So she's thrilled, by the way, just thrilled, because her pain is gone. She's sleeping better. And I'm feeling so happy, because I haven't seen this kind of thing in an adult change as quickly ever, I mean, it's really great because it's quick. It's helped. So you've pushed my therapy up a notch, okay? So this is an entire family. We talked about insurance and how expensive myofunctional therapy is and how are they going to pay for the braces. This is a family with 6 kids. And they own a private school. The mother's a teacher there. And she now is including exercises in the school. But the whole family did it together. And they all had tongue releases, expansion, and osteopathy. Okay, we can play the. Play the other one, too. So these are a couple exercises. They're sitting at their dining room table.
Oh.
Are you doing it too? Yeah!
Right.
Okay. So they had fun. Every week they drove 2 hours to my office. They'd bring 2 of the kids with each time. This little piece of dental wax, I use it like a lip bumper, like the orthodontists use the lip bumper. And they love it. They think it's fun, have pink teeth. So this is them when they're finished.
All finished, Skyly and Kinley. Look at their beautiful faces. Can you smile for me? Show me your spaces. Ah, that's what I love. I love seeing the spaces in between. And did you have fun with myofunctional therapy? Was it fun? What was the best part?
Getting the toy from the dentist.
Getting a toy from me?
Playing with Polly Pockets and getting the toy.
And playing with the Polly Pockets in my waiting room. Which exercise did you like the best? Did you like the button pull or the marshmallow twist? How about pucker power?
I like the one with the string and you have to try to go like this with it and get it all the way into your mouth.
Uh-huh.
Yeah,
Which
I
one
like
was
that one too.
you like that one too? And Mom, what did you think of myofunctional therapy? Do you think it helped them?
I think it definitely helped them. They both used to sleep with their mouths open, and now they have them closed and they can breathe through their nose properly. I think they're getting better sleep. Skyly used to have dark circles under her eyes, and she doesn't have that anymore.
Good.
And I think it's helped with their speech as well.
Yeah, I'm very excited.
Me too.
Thank you for being such great patients.
You're welcome. Thank you.
Mm-hmm.
But the fact that she's doing this in the schools, it's going to be great. So the lip exercises, people don't understand the power of the lips. The lips are attached all the way around in like a circular band. And when you put pressure to pull things forward, and you're working collaboratively because they did the typical Derek Nordstrom deal with the ALF appliance and the osteopathy every week and the myofunctional, but certainly any kind of a expander that moves things forward as well as wider, along with the myofunctional, along with the osteopathy, the collaboration is what works. So early intervention, prevention, pre and postnatal education Educate future parents on diet, breathing, mental health. When you get a patient who just gets married, say, yeah, we're going to try to have a family. That's when you need to educate. Educate the patients on the importance of nasal breathing, of swallowing and chewing correctly. And breastfeeding is critical. Frenum restriction with therapy. I can tell you at least twice a day I see a patient who's had a frenectomy and no therapy. The dentist said this would take care of it, but it doesn't work. It reattaches with scar tissue. You don't get the results. It makes it harder then to undo it. No pacifiers, spotted cups, osteopathy, or cranial, sacrocranial, some kind of cranial work, or a good chiropractor even that understands. Breathing education is wonderful, and the emotional value is critical, and then the genetic and epigenetic predisposition. So you have to look at what the parents look like, you know, and how there is a genetic component to this. Unfortunately, the future, we need more research. You're going to breastfeed with support, prevention with education, especially pregnant women. Check all freedoms at birth, treat early, develop a protocol for infants, normalize breathing, the mouth only with proper volume, muscles day and night during rest, speech, sport, and sleep. Teach tongue up, lips closed, introduce proper chewing, swallowing as early as possible. Even in babies, you can encourage that. Lip closed. Introduce proper chewing, swallowing, and co-treat sleep disorders with a well-trained myofunctional therapist. And the collaboration is the key. The vision for the AOMT is that every person who suffers can find treatment. The mission is to provide the best training possible and educate healthcare providers and include everyone. I mean, allergists are really important, gastroenterologists. You're working with gastroenterology now. I mean, we have to include all the specialties, ear, nose, and throat doctors, surgeons, sleep specialists. We need to educate them. And thank you so much for making me. If you have any questions, there's my email. You can email me. And thank you, Mark.